So Sait Naderi will talk about the reasons of implant failure. So Naderi, if you're ready, you can start.
Okay. Can you see my slide?
We can see
Yes.
it.
Okay. I will try to talk about the reasons of implant failures. Actually, I think most of us experience implant failure with the time. The main cause, actually, of the implant failure is the use of instrumentation in wrong patient with wrong diagnosis by wrong surgeon, using wrong implant and wrong technique. Probably one of these reasons are the major cause of implant failure. So actually in practice, we can see different types of implant failure. For example, as you can see here, we can see screw loosening, especially in patients with poor bone quality. It may cause pull out of the system. Screw fracture and rod fracture are another common complications. Rod sliding, graft and cage dislocation also is very important. And finally, as we discussed now, proximal junctional kyphosis also is another problem which we encounter in geriatric patients with degenerative spinal disorder. You can see here. So, a good spinal construct requires good anterior support, good sagittal balance, and good bone quality. It also requires implant-related factors, for example, implant morphology, selection of appropriate construct, and good construct length. Actually, if there is a complication, if there is an implant failure, sometimes we say this may be patient-related, this may be implant-related, but in the practice, complication is surgeon-related. If surgeon does not address anterior support, does not address sagittal balance or bone quality of the patient, this system, this implant may fail. So I will try to talk about these items now. Probably most important factor is presence of ventral vertebral column. Like that, I mean anterior support. In degenerative cases, actually, for example, in this case, we have anterior support. This is not like a burst fracture. This is so because we have a good vertebral body integrity, but there may be spondylolisthesis. In these cases, you may not address anterior vertebral body. You can prefer fixation even in these cases. But actually, even in these degenerative cases, intervertebral body fusion is important. This is so because interbody fusion not only increase the fusion, but also works as strut graft, but also increase the height of the vertebral intervertebral disc and foramina. Therefore, even in degenerative cases, we need to address anterior support. As Dr. Benzel mentioned, in normal situation, axial loading may cause loading to the vertebral bodies, and most of loading transfer from the up to the down through the vertebral body. In probably 80% of the loadings. But if there is a corpectomy or if there is burst fracture, then the load can transfer through the screw and rod. And with the time, it may cause fracture of the screw in most of cases in the below of the tulip of the pedicle screw. Therefore, in order to prevent such a complication, the best strategy is to add a corpectomy graft or cage. You can see here in a burst fracture, if you use a short fixation, with the time, axial loading may increase and finally the system may fail. In order to prevent such a complication, we have two options. First option is increasing of the posterior system, and the second is the use of anterior support, additional anterior support. I would like to show you some implant failure samples. For example, in this case, we use short segmental fixation in the presence of the burst fracture, and with the time, it causes screw fracture. In such a case, we needed to add maybe a longer instrumentation or use a cage here. You can see here another cases of the screw fracture in presence of the burst fracture here. The system has two screw below and only one segment screw in the upper level. And in the thoracolumbar area, it seems that it's not enough and it causes screw fracture. You can see similar story in different cases. For example, here also in the left side, you can see burst fracture and fracture of the screw below the tulip of the pedicle screw. In some cases, if you cannot restore the shape of the rod, you can experience rod fracture as well. This is also very important. You can see here rod fracture in the both sides. In order to prevent such complications, it's better to use longer instrumentations, particularly in the thoracolumbar area. In some cases, if the ligamentum flavum is intact, you can use ligamentotaxis in order to increase the height of the vertebral body, and also using long instrumentation in the thoracolumbar junction, you can prevent complications. Another option, as I mentioned, is the use of the anterior strut. In this case, you can see cage and anterior plate system. This works in many cases. Of course, in the thoracolumbar area, maybe a posterior longer fixation may provide a better implant. This is same for cervical area also. In one-level corpectomy, actually in most cases, if there is no problem in the posterior ligamentous structures, anterior plating may be enough. But if your system, a corpectomy, is in 2-level or 3-level, there is risk of failure in these cases much more. Therefore, in these cases, we need to add posterior fixation in order to increase stability of the operated level. What I told are about the corpectomy and burst fractures. But actually, we have a similar problem in the tumor cases. In tumor cases, we can see the common implant failures, what I told you, but there is a special fracture in the tumor cases, and this is rod fracture in these cases. This is so because in tumor cases, you resect, in some cases, all the vertebrae, I mean, vertebrectomy, both corpectomy and posterior structures. Therefore, the instability is much more, especially if there is history of radiotherapy. It doesn't matter before surgery or after surgery. If there is risk of radiotherapy, it causes many things in here, and resection of the more than 2 vertebral body also is another risk factor for implant failure in these cases. Also, a longer posterior fixation may prevent screw loosening. It does not prevent rod fracture. I would like to show you some cases. For example, here we have a tumor, and after resection of the vertebral body and some parts of the posterior vertebral structures, we perform construction using a cage and 2-level above, 2-level below. But with the time, we experienced rod fracture. So, what to do in these cases? This rod fracture occurred after radiotherapy and after flexion, probably 3 months after surgery. Therefore, in such a case, we need to restore the system. We can increase the length of the instrumentation. We can use 2-rod technique, and also we can change, if possible, we can choose cobalt chrome rod. In these cases, these are much more resistant than titanium rods. This is also an aggressive osteoblastoma cases, 2-level corpectomy, and we resected some parts of the posterior also. With the time, we experienced also here rod fracture. You can see here rod fracture. And in this case also, we extend the system here, and we use 2-rod technique. In another case, even we restored after corpectomy using a cage and anterolateral plating, but even this case had anterior plating system. This system failed, and it was necessary to restore using the posterior lung instrumentation. Therefore, I would like to emphasize that in tumor cases, it's better to use anterior and posterior fixation in order to provide the best stability, especially in cases with anterior plus posterior resection. In summary, solution of the stabilization in tumor cases include the use of cobalt crown rods. These are very strong, and you can use additional rod in the posterior instrumentation to reinforce the system. Another problem is sagittal balance. Actually, Onur discussed this with Dr. Benzel, especially in the recent 10 or 20 years, we focused on the sagittal balance of the cases. I want just to summarize something. In adult spine surgery, we know the rules, but when we do surgery in a pediatric case, we should know that a pediatric spine is not only a small spine, and we cannot use the same rules. Similarly, in geriatric cases, we have two major problems. In geriatric cases, the first problem is poor bone quality, especially in post-menopausal females. And the second one is sagittal imbalance. Therefore, it's a good idea to measure sagittal geometric parameters, for example, C2 slope angle, C2, C7 SVA, and in the thoracic and the lumbar spine surgery also, it's better to measure kyphosis and lordosis and pelvic parameters. As Dr. Benzel mentioned, normally SVA is across the L5-S1 disc in the posterior area, but in most of geriatric cases, it's a little in the front of the vertebral body. But in sagittal imbalance cases, it's probably 10 centimeter, 15 centimeter in the front of the L5-S1 level. And instrumentation in this case is different, in this case different, and in this case you need to address this problem. Therefore, it's better to do osteotomies in these cases in order to bring case to this or to this position or close to this position and then fixate in this position. If there is no problem, in case of degenerative scoliosis or spondylolisthesis, maybe such a system may be enough. But in cases with, in which SVA is much more in the front, probably 10 centimeter or 15 centimeter in the front of the L5-S1, this system will fail, as in this case. And therefore, in such cases, it's better to address this problem. And after osteotomies, you can extend the system to the upper levels. If you do, you prevent proximal junctional kyphosis. There are, of course, many strategies to prevent proximal junctional kyphosis: osteotomies, the use of hook in the proximal and cement in the upper level, dynamic stabilization, and different rods. So another problem is bone quality. This is so in most cases, as I mentioned, poor bone quality is important. And even if you use best implants, if there is poor bone quality, this system may fail and you may experience pull out of the system. Therefore, we can use cements or hooks or another techniques. For example, triangulation technique screws may decrease the risk of the pull out in these cases. And also more fixation points, for example, here, and also hooks or transverse elements. All these may help stability of the implant. But nevertheless, poor bone quality is big problem, and when you have poor bone quality, it's better to think about the surgery, decision for surgery twice, or this is very important. Implant-related problems are also important. We have different types of the screw. We need to know that outer diameter and inner diameter of the our screws are important. The outer diameter reflects pull-out resistance, and inner diameter reflects strength of the system. We know that Dr. Benzel also showed this to you. There is relation between the screw inner diameter and the strength of the screw. Actually, cube of the diameter of the screw reflects its strength. For example, in a screw with 5 millimeter diameter, the strength is 125, but if it is 6 millimeter, the strength is 216, almost twice of the 5 millimeter. This is very important. Therefore, in osteoporotic cases, it's better to use the thicker screw also. Selection of appropriate implant also is important, especially in selected scoliosis or osteoporotic cases. We can choose also additional hook also for stability. But we should know that pedicle screw, the force center for pedicle screw is close to the center of the vertebral body, but force center for hook is below to the vertebral body. Construct length is very important. Dr. Benzel talked about the moment and force and distance. This is very important because if the distance is long, using the less force, you can provide the same moment. In person one, this is a fulcrum. Distance is 2 meters. Here is 1 meter. Here is we have a larger man, but here is we have small, but there is equality. This is because of distance of the moment arm. Therefore, if there is risk of failure, if your anterior support is enough, it's better to use longer instrumentation, as I mentioned before. So, finally, I would like to talk about some messages. Implant failure may be secondary to the patient or implant-related factors. Lack of anterior support and sagittal imbalance are the major patient-related factors. Anterior reconstruction with posterior stabilization are the choice of surgery stabilization in case of lack of anterior support and kyphotic cases. Fresh traumatic cases require longer posterior construct. Cases with sagittal imbalance may require osteotomy. And the best coronary correction can be achieved using A-lift and X-lift. Tumor cases may require longer instrumentation or double rod or cobalt chrome rod to provide stability. Thank you for your attention.
Naderi, thank you so much for your presentation. Yahya is there? Are you there? Yahya has a question for Dr. Benzel. He is asking that, what do you think for pediatric cervical kyphotic deformity? Do you use the viscoelaxity, for example, for preoperative or preoperative traction instead of osteotomy? Dr. Benzel? Sorry, we cannot hear you.
You must unmute yourself.
Viscoelasticity is the gradual deformation of a body, such as the spine, with the application of a constant load. Obviously, a pediatric spine is going to be more elastic than an adult spine, and henceforth would be more amenable to this. So, for example, if you're going to correct a kyphotic deformity, doing via a ventral approach, doing relaxation strategies such as discectomy and potentially putting in pins, etc., with a shoulder a pad put under the shoulder, allowing the head to extend, can gain a lot of correction with minimal or less risk than with trying to muscle the hardware in when with pediatric bone, the room for screws, etc., and the strength of the screws may be suboptimal.
Thank you. Harun Pillai is asking that if longer construct is used, do you use additional bone graft or do you depend on the rods and screws? Sait Naderi, can you? Yeah.
Yes. I think fusion instrumentation mismatch is a big problem. It also may cause failure of the system. Therefore, there should be enough fusion. No mismatch.
Okay, Vehbi Gülmen from Turkey is asking that. My question is for all participants. Dynamic instrumentation has become widely used in recent years. Are dynamic instrumentation for stabilization more prone to fail? If it's so, what are the main causes of failure? He's asking about dynamic instrumentation. What do you think about it?
Well, first of all, it has a role, but not in all cases. I would, when there is overt instability, dynamic instrumentation probably doesn't play a role at all. But in degenerative disease, dynamic plates in the ventral cervical spine may be useful to share loads. In other words, the surgeon controls the curvature by the curve of the spine, by the curvature of the plate, but then allows axial compression of an intervening strut or struts so that the bone healing enhancing forces, as described by Wolf, are enhanced.
So Harun is asking again, is there any situation where do you only use rods and screws and no bone fusion? I think Harun doesn't want to use bone. So Edwin.
Sait, go ahead.
Yeah. Edwin from Bulgaria, what do you think in long-term concept of using vertebroplasty in cases which need anterior column support in lumbar levels? What do you think about the using of vertebroplasty instead of using anterior column support in the lumbar area? So it depends on patient to patient.
Yeah, it does. To answer the first question, I would consider instrumentation without fusion in metastatic cancer patients. That sometimes is our only alternative. Now here, what was the question again?
So Edwin is asking that, do you prefer vertebroplasty? What do you think about vertebroplasty instead of using vertebral column support in the lumbar area?
Well, vertebroplasty
Yeah,
is probably not optimal in a non-cancer patient because eventually it will fail, and henceforth I would opt for standard reconstructive procedures.
Yeah. So, Nader, what do you think about vertebroplasty in the lumbar area instead of using anterior column support?
In cases of tumor, I think I use in selected cases. There is no problem. If there is no, if there is osteolytic changes and no compression in the vertebral body, I use vertebroplasty, and if need be, I add posterior instrumentation also. In some selected cases of osteoporosis also, if there is indication for instrumentation, even in some cases I use, but not for fresh fractures.
So Naderi, what do you think? Yunus Hermanto Bandung is asking that. In patients with low body mass index in osteoporotic, is it possible to improve bone quality by using biphosphonate and improving general health prior to the surgery of long construct fixation?
Actually, we use QCT in all geriatric cases. And if the T-score is more than -2.5, that means these are severe osteoporotic cases. In severe osteoporotic cases, we first refer case to the physical therapy specialist. They start to use some vaccines each 6 months. But, you know, they start to use the treatment by biophosphonates and new also treatments. But then I operate the case. If the surgical situation is emergent, after the first treatment or osteoporosis treatment, I operate cases.
Thank you so much.
Mean, in summary, we use both treatments.
Thank you so much. There were good questions and good answers. So I think we have to pass other speaker. Yes.
Onur.
Yes.
There is one question, probably Ed Menzel can answer this. What is the basis of fatigue fraction?
Of what?
Fatigue fraction.
Fatigue fracture?
Yeah.
Any rod, no matter how strong, placed in even the lightest of patients, can fracture over time. Basically, fatigue fractures are a gradual weakening of a implant, say a rod, in areas of maximal stress application. So flexion extension over long periods of time can weaken the material and then ultimately result in fracture.
And another question is that in two rods technique, the two rods shouldn't cover entire length of construct. Is it true?
Yes. Actually, we
entire
use
length. But you have shown us the examples that the double rods were not entire length.
Yeah, actually, the use of double rod technique in the lumbosacral area is well known. We use these in lumbopelvic fixation cases. This is another story. But here, in tumor cases, there is much more stress over the rods. Therefore, it's advised to use a short rod in order to absorb some parts of the stress, and then second rod. This is another story. This is not like a lumbosacral double rod technique. Two different systems.